So today new topic in ICU, sepsis and septic shock. Before discussing the sepsis and septic shock, we must know few definitions, and definitions include particular words. Okay, so what is sepsis? Sepsis is nothing but life-threatening organ dysfunction caused by dysregulated host response to an infection. So sepsis is life-threatening organ dysfunction caused by dysregulated host response to an infection. So what is organ dysfunction? Organ dysfunction is nothing but SOPA score more than or equal to 2. What is septic shock? Septic shock is nothing but requirement of vasopressor to maintain mean arterial pressure more than 60 millimeters of mercury and lactate more than 2 millimole per liter in absence of hypovolemia. So poor outcome of sepsis is judged by quick SOPA score, and quick SOPA score includes three parameters: a respiratory rate more than 22 per minute, altered mentation, systolic blood pressure less than 60 is 100 millimeters of mercury. Sorry, systolic blood pressure less than 100 millimeters of mercury. So what are the common medications which are used in septic shock? So number one, vasopressors. So number of vasopressors are there. NORAD in a dose of 0.05 to 0.5 microgram per kg per minute. Dopamine 5 to 20 microgram per kg per minute. Adrenaline 0.05 to 2 microgram per kg per minute. Phenylephrine 2 to 10 microgram per kg per minute. Vasopressin 0.04 units per kg per minute. Inotropes. The most commonly used inotrope is dobutamine 2.5 to 10 microgram per kg per minute. Corticosteroids, we commonly use hydrocortisone 50 milligrams QID, and antibiotic, which we'll discuss later on. So what is the fluid management in septic shock? So we know clinical features of sepsis like systolic blood pressure less than 90 millimeters of mercury, mean arterial pressure less than 60 millimeters of mercury, lactate more than 2 millimole per liter, and jugular venous concentration less than 70%. So if this criteria are fulfilled, initially fluid bolus is 20 ml per kg NS or RL or 5% albumin we give. If still blood pressure after giving this fluid, still blood pressure is less than systolic blood pressure less than 90 and mean arterial pressure less than 60. So what will you do? First of all, we insert a CVP line, a CVP catheter, and measure central venous pressure. If there are two conditions now, after inserting a central venous catheter, we take CVP if CVP is more than 8 and if CVP is less than 8. Suppose if CVP is less than 8, what we will do? We will administer NSRL or 5% albumin if CVP is less than 8. So there is fluid deficit, we must administer NSRL 5% albumin. If CVP is more than 8, we will measure mean arterial pressure. Now there are two conditions. If mean arterial pressure is more than 60, mean arterial pressure less than 60. If mean arterial pressure is less than 60 millimeters of mercury, what we will do? We will give NARAD or vasopressin. If mean arterial pressure is more than 60, what will you do? We will measure central venous oxygen concentration. If central venous oxygen concentration less than 70%, if central oxygen concentration more than 70%, if central venous oxygen concentration less than 70%, we will look for HB, and if HB is less than 8, we will give blood transfusion. If cardiac index is less than 3.5, we will apply dobutamine. And now other condition, when central venous oxygen concentration is more than 70%, so we have achieved our goal, and we have achieved all our goals. So and vasopressor is still required. So what we'll see, if vasopressor is still required, we will give some adjuvant therapy. If vasopressor is not required, our therapy is complete. So what is role of antibiotic is in septic shock? So basically septic shock in septic shock, antibiotics are very important. There are 3 bundles: 1 hour bundle, 3 hour bundle, and 6 hour bundle. We will see later on. Okay, there are 3 bundles. But if patient is immunocompromised, yes, if patient is immunocompromised, we will take an expert opinion for opportunistic infections, and we will treat all opportunistic infection. If patient is not immunocompromised, what will you do? We will think about likely bacterial infection. At if at risk for healthcare associated infection, if patient is at risk for healthcare associated infection, if patient at risk, then what we will do, we will consider resistant organisms like MRSA, Pseudomonas, Acinetobacter, Klebsiella, E. coli, etc. If there is no risk for healthcare associated infection, we will consider community acquired or community based pathogens, which include Streptococcus pneumoniae, E. coli, Legionella, MRSA, Haemophilus influenzae, Klebsiella, etc. etc. So select antibiotics depending upon this. Most commonly, we select antibiotics like ceftriaxone, fluoroquinolones, influoroquinolones, levofloxacin, moxifloxacin, ciprofloxacin, ampicillin, sulbactam combination, in ertapenem, meropenem, some microlide like azithromycin, clarithromycin, and telithromycin. If organisms are resistant, we mostly use broad spectrum antibiotics, which includes broad spectrum antibiotics: cefepime, ceftazidime, cefepime, avibactam, cephorezone, cefoperazone, sulbactam, carbapenems like imipenem, meropenem, doropenem, beta-lactam like piperacillin, tazobactam, fluoroquinolones like ciprofloxacin, levofloxacin, uh, amyloglycoside like gentamicin, tobramycin, amikacin. Gentamicin is known using nowadays, commonly used is amikacin. MRSA, if MRSA is found, we use vancomycin, tigecycline, linezolid, or daptomycin. So all antibiotics are important. They have different doses. They have different complications. They have specific drug administration during CKD. Okay, so we'll discuss later on. Thank you.